Hello and welcome back to the Essential Together National Huddle series. My name is Carol Fankotz and I'm going to be your host for today's huddle. I hope you all had a wonderful summer and are easing back into the fall now. So we are pleased to offer this session with simultaneous interpretation. And please do note that the session is being recorded and the recording will be available after the session. If you have not done so, please do take a moment now to respond to the poll question on your screen. Please scroll down to see all the questions in both English and French, and be sure to click the submit button to send your responses to us. If you would like to hear the voice of our interpreter today, please select the French from the interpretation menu at the bottom of your screen. At Healthcare Excellence Canada, we are early on our journey of reconciliation and how we develop meaningful relationships and partnerships with First Nations, Inuit, and Métis governments, organizations, and communities. And as part of this journey, and as noted on our strategic plan, we strive to support cultural safety and humility in the healthcare system and to enhance the capacity of health systems to meet the needs of First Nations, Inuit, and Métis. And we are all gathering here today across Turtle Island, or Canada. And I am joining you happily from the Healthcare Excellence Canada offices, which are located on the unceded, unsurrendered territory of the Algonquin people, and that is here in Ottawa. We welcome you to please introduce yourselves in the chat box. Let us know where you are joining us from today, and to reflect on the territory that you are on. And if you're unfamiliar with what territory you're on and the history that was built and preceded it, we have provided a link in the chat box to Native Land Digital, which is a great resource. Now, as many of you, and I will ask if maybe we can advance the slides, as many of you are aware, we at Healthcare Excellence Canada are firmly committed to partnering meaningfully with patients, with caregivers, and communities to shape a future where everyone in Canada has safe and high quality care. And we know that our work is better when we do it in collaboration and partnership, to ensure that improvements in healthcare and in the health system really are meeting the needs and priorities of those using and providing care in the system. So a little bit about Essential Together. For those of you that have been joining our huddles in the past, and for those of you that are new, the program of Essential Together was developed to support the safe reintegration of essential care partners in health and care settings throughout the pandemic. And so this is a program that offers support for the implementation of this co-developed policy guidance. In particular, Essential Together supports organizations to welcome back essential care partners by presenting the evidence, by providing policy guidance, by hosting learning huddles such as this, and providing tons of resources and tools, including a change package to help support teams. As well, we do point you to the Essential Together Pledge, and we are hoping that your organization will consider making this commitment to essential care partners. So foundational to the work of Essential Together really are three key principles. And I know that we talk about these a lot. And as we move forward in thinking about the what next and how we further embed not only these principles, but this notion of Essential Together, they remain core to the work that we're doing. The first principle is really about how is it that we differentiate between visitors and family and other caregivers as essential to the care of their loved ones? How is it that we recognize and value caregivers as essential? And thirdly, which is really what Adrienne and I are going to be speaking to you about, it's really how is it that we ensure patients, families, and caregivers have a voice, not only in the development of policies, but in practices and in the care across the health system. And so, as mentioned today, we'll go to the next slide, please. Adrian and I are going to build on this thread of engagement. We certainly saw through the pandemic, those organizations that engaged and engaged well ended up with different kinds of policies, different kinds of practices as they related to essential care partners throughout the pandemic. We're going to start talking about building and sustaining engagement capable environments as part of building a resilient healthcare system. So I'm going to introduce Adrian. I've had the great pleasure of working with her over the past year and a half. Adrian is an embedded patient partner here at Healthcare Excellence Canada as part of our staff. Really, Adrian is a patient leader. She's an advocate for patient engagement and partnership in healthcare improvement. And a lot of this stemmed from how she was engaging with the healthcare system after finding out her youngest daughter was diagnosed with autism spectrum disorder. And Adrian really embarked on this journey to partner meaningfully with local and national organizations to advance person-centered and really patient partnership in care through effective and meaningful engagement. She's been the past co-chair of Holland Bloorview Kids Rehab's Family Advisory Committee. She's a graduate of Canada's first Family as Faculty. She's a patient advisor and hub team member of ECHO Autism Ontario. And she's one of Canada's first faculty first patient surveyors with Accreditation Canada. And so we're so lucky to have Adrian as part of our HEC team as we're building out our engagement work as a new organization. As noted off the top, I'm Carol Fankotz. I'm the Director of Patient Engagement and Partnerships here at Healthcare Excellence Canada. I've had a long history in the field of engagement, first as a frontline clinician, working with patients and families in quality improvement and safety initiatives within a large academic teaching hospital in Toronto, and as an academic who has really studied the field intensely. But I would say my most profound learning in this area of engagement was really as a caregiver to my dad, who had a lengthy hospital stay before he passed away. And I take what I have learned through all of this with me as we continue to advance the work of engagement. So I'm going to pass it over to Adrian now, who's going to get us started thinking about engagement capable environments. Over to you, Adrian.
Thanks so much, Carol. And hello, everyone. My name is Adrienne Zaram, and as Carol noted, I'm an embedded patient partner on the Patient Engagement and Partnerships team at Healthcare Excellence Canada. My pronouns are she and her, and I'm joining you today from my home office in Toronto, which is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. So Carol and I are really thrilled to be here with you all, and we're looking forward to exploring how engagement capable environments are really created and sustained. So next slide. Over the next 20 minutes, we'll explore three things. Firstly, we'll talk about what happened to engagement throughout COVID-19. We'll then move on to thinking through how we might work together to build resilience for engagement and talk specifically about what engagement capable environments really are. And finally, Carol will introduce us to a practical tool, an organizational self-assessment readiness tool that can help groups and organizations assess whether their environments are indeed engagement capable. So on the next slide, we'll talk about, what happened to engagement throughout COVID-19. It feels like the pandemic changed just about every part of our life and our world, and engagement wasn't exempt from this. So we're going to dive a little bit into the details here in regards to engagement. So on the next slide, thanks to a number of really dedicated academics committed to studying emerging trends in patient engagement, we have research related to the impacts of the pandemic on patient engagement. So this paper, entitled "The Impact of COVID-19 on Patient Engagement in the Health System," results from a pan-Canadian survey of patient, family, and caregiver partners, published by Dr. Julia Abelson and colleagues from McMaster University in the fall of 2020, is one really good example. And so through a survey that reached hundreds of patients, family, and caregiver partners, Dr. Abelson and her colleagues found that particularly in the early days of the pandemic, a quarter of patient partners reported that engagement work had stopped altogether. 62% reported that there was at least a temporary or partial stoppage in engagement. But the silver lining, remarkably, just over 11% said that there was an increase in engagement. And for reference, patient partners were noting their partnership roles in a wide variety of healthcare institutions, from hospitals to community to long-term care homes and other congregate settings. So intuitively and through the research, we know that patient engagement was impacted by the pandemic. And it's important for us to understand those impacts, to understand what was lost, but also to understand what was gained. Because as we'll see, there were some significant gains, and we really don't want to lose sight of that. But first, let's look at what's lost when we're not engaging. So next slide, please. So what's lost when we're not engaging? At the direct care level, we know we've seen many devastating impacts when patients, families, and caregivers are not engaged in patient care. And in the extreme cases, when essential care partners are not allowed to be physically present to partner in care. So we've seen poor care transitions, implications for safety and quality of care, and an impact on outcomes for patients, care partners, and providers. And we know that there's many reasons for this: staff shortages, lack of personal protection equipment, and fear and uncertainty about the virus, particularly in the early days of COVID. But the impacts are numerous, and we see that many harms have resulted. At the organization level, rapid changes were being made to policies and practices, and for the most part, changes were being made without input from those that would be most impacted, i.e. patients, families, and their caregivers. And what was most shocking for many of us was the realization that the significant gains that we felt we'd made related to person-centered and partnered practices in care seemed to disappear overnight. And when the crisis hit, the default seemed to be, in some cases, to go back to paternalistic patterns in decision-making and more top-down approaches. At the system level, there were many pivots and shifts made to respond to the uncertainties of the pandemic. And many of these pivots and shifts were made without fully accounting for the other potential risks that would emerge because of these changes. So next slide. So there were a number of pandemic-related losses, yes, but there were also a number of really significant gains, and we don't want to lose the learnings from these. So we'll take a look at a few. Like the rapid shift from in-person care to virtual care, some found virtual engagement a valuable way to continue engagement work, as it provided a safe method for people to gather and continue to work together. And while there remains concern about the digital divide, what many found was that they were able to widen their circles of engagement to include many more people with diverse perspectives in their engagement practice. These people could now become involved because they could attend meetings virtually, when prior to the pandemic, in-person engagement had been a barrier. And new structures actually emerged that didn't exist previously. So at Kingston General Hospital, a group of patients and staff, fondly referred to as the Balzac Coffee Group, came together to meet at a local coffee shop to continue their engagement work when pandemic restrictions limited them from meeting in person at the hospital. And at Huddle and Bloorview, a pediatric rehab hospital here in Toronto, where I partner, we created a virtual rapid response family leader team who could activate quickly, often in as little as 2 hours, to provide input and guidance on key issues when timelines were tight. And for many, engagement efforts in a time of crisis helped to build trust and strengthen relationships when both parties stayed committed to their work at hand. So on the next slide, we'll look at what enabled some of these gains. So we've been working with a researcher from the University of Toronto to dig into a number of cases across the country to better understand organizations who saw gains in their engagement practice despite pandemic times. And we found a number of core elements that enable ongoing and strengthened engagement. The first of those being leadership. So where leadership saw and valued the need to bring in the perspectives of those receiving care and those most impacted by the decisions being made, leaders consequently made engagement more of an expectation, and their respective organizations remained committed to it. And maturation of context, was an enabler. So having an entrenched philosophy of patient and family-centered care really did matter. And in cases where organizations were significantly mature, this enabled them to continue their already strong engagement practice. And trusting relationships were definitely an enabler. Organizations who already had developed trusting relationships with patient partners were in a better position to turn to these partners in times of crisis to work together, even when the work was pretty difficult. Solid existing structures also enabled gains. Those organizations who had solid structures in place, whether it be through advisory groups or teams with embedded patient partners, those organizations were able to turn to and build on their structures even when times were tough. And willing partners made a difference. So established practice and structures were important, but having a network of patient partners who were willing to continue to be being involved despite being smack in the middle of a pandemic, made a big difference to an organization's ability to continue their engagement practice. So here I'd like to pass the baton back to Carol to talk us through building resilience for engagement through creating, sustaining, and evolving engagement capable environments.
Thanks so much, Adrienne, for that setup and for really reflecting on, what have we been through over the last 2.5 years? And really, what is it that we want to become and to make sure that we've really embedded in the years ahead? And so one of the key focus areas in the new 5-year strategy here at Healthcare Excellence Canada is pandemic recovery and resilience. And one of the main areas within this, this focus area here at HEC relates to patient engagement and partnership. How is it that we build resilience for engagement, which is really what Adrienne described, that slipped away, particularly in the early days when the pandemic hit? And how is it that we make engagement to be seen as necessary, essential, especially when there is a crisis, rather than a nice to have? So next slide, please. We would argue that it is about building engagement capabilities now. And for those organizations that dug in on their engagement efforts through the pandemic, they had done this work already. So when we talk about an engagement capable environment, what are we talking about? So I would say that it is one that has developed a culture for engagement and partnership that is often founded on this philosophy of person-centered care. Engagement capable environments are oriented towards seeking out, validating, and understanding the importance of experiential knowledge. How is it that patient caregivers are experiencing their care? And how is it that we, within the health system, are really learning from these experiences and then responding to the opportunities ahead? The building of trusting relationships are at the core of engagement capable environments, and engagement occurs at all levels of the health system, at the point of care, in quality and safety work across organizations, in the building of processes and systems of care, policymaking, research, and in health professional education. Next slide, please. So we know that engaging with patients and caregivers at all levels of the system makes a difference, and the evidence continues to grow. We've seen demonstrations of improved patient safety, improved patient outcomes and wellness, improved patient experience, and for providers, an improvement in workplace culture and joy in work, and for the system, lower costs where there is value for money. So when we think about establishing engagement capable environments, and we're going to go to the next slide then. They are fundamentally, engagement capable environments are fundamentally built on 3 main pillars. And I'm going to offer a thanks to our Essential Together team. They've just popped a link into the chat. I welcome you to click on that link. You can turn to page 5 where you will see this diagram and we'll be able to read it more clearly. But engagement capable environments, as I said, are fundamentally built on these 3 pillars. How is it that we prepare patients, caregivers to be involved and work together with us? How do we prepare staff and healthcare teams to work together with patients and caregivers in a different way? And how is it that leaders actually lead and make expectations known for engagement? All of these pillars are interrelated and interdependent. And at their core, they are based on relationships. We all know engagement is relational work. And all of this happens within a philosophy of care that is centered on the person, on their family and caregivers, and how we can partner with them. So we're going to dive into what we call the engagement capable environments organizational self-assessment tool. And again, the link that was put into the chat previously will have the tool there for you. So the tool itself was born out of work that we have done over years in the area of quality and safety improvement and engaging with patients and families to do this work. We've also done a series of case studies and research that we've done in this area. And we began to really flesh out, what does it take to do engagement well? All of this was put together into this self-assessment tool, and we sought inputs, and many of you may have provided inputs that are on this call now, but from engagement leaders across the country, from patient partners, and from healthcare leaders that really had been involved in engagement work, understood what it would take, and can reflect on the number of elements that you will find in this tool. So how do you use the tool? It is really meant to be a team-based reflective exercise that helps you actually consider the current state. Are you doing these things? Do you have them in place now? And what are the opportunities for you in moving forward? It helps you to see where your strengths are for engagement and where you can improve and reflect on. And the tool can be used in many settings. Across with a team that has just completed an engagement initiative, across an organization, in research settings, and in practice settings, really anywhere where engagement is happening. And what we want to do is invite patient partners, the healthcare team and staff that have been involved in engagement, and organizational leaders within the organization or within the initiative or research team, that they independently complete all three sections of the tool. Once they have done that, they come together to discuss their perceptions of each of the pillars. And I think it's always interesting because you may think that you are doing something, but how it is perceived by others is what I think adds to the richness of the conversation. So we're going to dive into the tool itself. And again, I welcome you to click on the link because you're going to be able to see the tool. We're going to start with the pillar of patient partners. How is it that we are providing opportunities for engagement? How are we developing capacity to support patient partners in their work with us? And how are we preparing patient partners for the work ahead? So again, take a look at the tool and you're going to see a number of elements listed. So I want you to reflect on, how is it that you prepare patient partners in your work? Are there clear roles and expectations in the work that you're doing together? Have you established these clearly? How are you looping back with patient partners after an engagement initiative so that they know what has happened to the work and what has happened to their contributions? How are patient partners being recognized for their contributions? And as we know, recognition comes in many forms, including compensation. And what mechanisms do you have in place that help them orient to the work ahead, to your organization? And what kinds of supports are there in place that help to support patient partners in the moment, a buddy system, so to speak? And are there ways that you or your organization actually support the capacity development of patient partners? And again, you will note in the tool, you are asked to consider, is this something that you're currently doing? Yes, no, somewhat, or don't know. So we're going to look now at the next pillar, staff and healthcare teams. So what's been fascinating in our learnings with teams across the country is actually the need to focus very intentionally on how we're preparing staff and teams to engage. Now, for example, does staff have clarity on why patients are being asked to engage, to come to the table in the first place? Is there an expectation to do this work? Is there a clarity of the roles that patient partners are taking on? Is there an understanding that staff have of the principles of person-centered and partnered care? What does this really mean in the work? Do staff have an understanding of inherent power dynamics that are at play? And how is it that staff actually seek to create a safe space so that people can contribute to the best of their ability? And for staff, are there resources and structures in place that can support them as they are seeking to engage? How is it that they're looping back to let patients know of the outcomes? And are they thinking about lots of different ways that they can really truly hear what are those patient experiences that are going to be important in improvement work? And are they seeking ways to improve how they're actually doing engagement? And, I reflect on a number of organizations and what I've seen in practice. And, a lot of this often comes from patient experience or patient engagement offices that are there to support teams through their engagement efforts, engagement offices that help teams recruit patient partners, and then help them to initiate the conversations as they're starting. So those are some ways in thinking about what does it look like on the ground. And then as we move to the third pillar of leadership, and arguably, we can say that none of this engagement work is going to happen unless we actually have strong leaders that set the expectation and, importantly, the accountabilities for engagement. They set the tone, they're going to role model behaviors, and again, importantly, we know this work cannot happen off the side of someone's desk. So how are leaders putting resources in place to ensure that engagement is going to be done well and be done in a meaningful way? Leaders themselves are those that are truly engagement leaders, are actively seeking out patient experience. So what we've seen in throughout the years are things like leadership walkabouts. So how is it that leaders actually have conversations with patients and their caregivers to understand what are those experiences of care? But it needs to take the step beyond. So then what are leaders? How are they actively listening? How are they acting with humility? But then what are they actually doing with what they're hearing? How is it driving the improvements that are being set out across the organization? We also want to think about how are leaders seeking out diversity in the voices that they're looking to hear from. And how leaders are creating the space to actually make sure that engagement happens, that they're putting patient partners in positions of authority, like at governance tables, at other decision-making tables, on hiring panels, as chairs or co-chairs of committees, and even, as we've done at HEC, in staff roles. And it's important that I go back to the accountability. How are they evaluating and monitoring the activities to ensure that the commitment to engagement is realized? So as, oops, sorry, I'm going to continue on. So I'm going to ask for the next slide then to reiterate. These are the three pillars again of engagement capable environments. They're interconnected, they're interdependent. You cannot have an engagement capable environment without having all three in place. And I go back to it starts with relationship. Have you ever done anything meaningful in your work where you have not developed a relationship with those that you're working with? And so again, this engagement capable environments tool is meant to help you examine each of these pillars closely to allow you to reflect and to consider all of the things that are happening within your organization now. And then what are the opportunities to shore up your engagement practices to truly build resiliency into your engagement work? So back to Adrienne to then wrap us up.
Thanks so much, Carol. So we'll chat a little bit about places to start. I'd say firstly, we need to be grounded in the lived experience of people who use the system. And to do this, we need to appreciate that patient engagement is about understanding the lived experience of those using the system and understanding that their experience is different from that of a healthcare employee. It's about understanding, particularly in our evidence-based world of healthcare, that evidence and knowledge comes in many, many forms, and that lived experience is indeed a form of evidence and knowledge. We need to approach the work with humility. Healthcare leaders and providers are experts in many things, but they can really never be an expert in a patient or caregiver's lived experience. Only that person holds that expertise, and we need to really value it as that expertise. As Carol noted, relationships are at the core of what we do, and fundamentally, healthcare really is a human endeavor. And as the pandemic has revealed very starkly, inequalities in society and health do exist. We need to be attentive to these inequalities. And so we'd encourage you to think about who you're engaging with, who you're not engaging with, and how you might be able to be more inclusive in your work. We often talk about, who's at the table. Perhaps it's time to start to rethink the quote unquote table, to imagine how we might go about reaching out to patients and communities and what that might look like. And finally, the reality is that with this work, there will never be perfection. You'll never have planned enough or left enough time. That's just the reality of life, but it's no reason to kind of avoid just getting started. Typically, that's just what we need to do, is to just start, and things evolve as they go. So on the next slide, if you're interested in learning more, we have lots of resources available to you on our Patient Engagement Resource Hub. The Hub has many practical tools related to engaging patients and families to improve the quality and safety of healthcare. The Hub itself is going to be migrated to HEC's website shortly, and we do update it regularly, so do check it frequently if you're interested in materials. And now we have the opportunity to take questions. And so we'd invite people to unmute their mic and share any questions or comments that they have, or to use the chat box to ask questions or make comments.
I would like to just add, Esha, thank you for your comments about how is it that we're building tools and resources, and the importance of ensuring that we are bringing in the voices of patients and families to help to enhance and to really, what I would say, co-develop and co-build the tools that we would want to say, to see. I think perhaps as people are thinking about their questions, and thanks, Lisa, for your comments in the chat. Maybe I can ask you, Adrian, as you are a patient partner, you're a patient leader, you're a patient surveyor, and the kinds of things that you have seen in various organizations across this country. I know we at HEC certainly see a lot of teams across Canada who are doing quality and safety work and seeking to embed patients and families and caregivers in their work. But I'm wondering if you can point to any key gems that really have stuck out in your time as a patient partner.
Good question. We talk about how leadership buy-in is so vital, and I think that I see that so often, and it's so very important, because without it, there typically isn't consistency, and kind of patient-centered and patient-partnered approaches don't have longevity if leaders aren't firmly committed to this kind of an approach. It's one thing to create resources and documents and to talk about it, but it's another to live and breathe it. Your examples of walkabouts are great, and I think in organizations where leaders are really committed to this, they're spending time with people, they're spending time with patients and with caregivers and with essential care partners out, on the floors with staff, understanding this work, and then working with management to figure out even improved approaches to embedding the perspectives of people. So I think leadership really is so vitally important, and if that's not a consistent presence and force in this work, it doesn't typically have the longevity that it can when that's present.
Thanks for that reflection. I do see that there's a question in the chat. I'm going to add, before I go to the question, Katarina, I'm going to add something else about leadership. I know in my experience, the one thing that I saw that really made a difference in sort of in the way that work was done, in changing that how, was a senior leader where other leaders had to go to vet their ideas for improvement, and the senior leader would just simply say to them, and how is it that you've engaged patients and families to know that this is a priority? And that was the only question that they had to ask, and ask it a few times, so that anybody going to this leader knew that they couldn't bring an idea forward unless they were clear on how is it that they've engaged with patients and families to know that this idea was important to begin with. And that kind of engagement could take many different forms, but it was a fundamental question that was asked from the outset that really made a difference to then how this team, this organization operated moving forward.
Yeah.
Adrian, do you want to go to the question that was in the chat from Katerina?
I am just looking here. Is it okay to email to ask for advice on lived experience? It would be about healthcare quality. I don't know that I completely understand the question. Katerina, did you want to expand a little bit on that?
Hi there. I was just wondering if asking about a lived experience in healthcare would be acceptable to email to you, as for example, if somebody had a personal healthcare experience and wanted some direction on just some direction on the situation and other contacts, would that be okay to send to you, or is that not okay?
No, thank you. It's, you know what, it's a really salient point, because we've had a number of patient partners and patients and caregivers reach out to us. I think, within our name, Healthcare Excellence Canada, I think is the intuitive assumption that we might be responsible for ensuring that care is excellent in Canada, and perhaps helping people to ensure that that happens. Unfortunately, it's outside of our scope. And so we try to be very cautious about what we advise people. We are working on a page on our website that would help direct people, but essentially, our role is to really kind of help support the system and not to support individual people. And so we often will recommend that patients look to ombudsmen or to, colleges associated with professional bodies or that sort of a thing, because unfortunately that isn't our role in the system.
Thanks, that makes sense. I just thought I would ask, just in case, you never know. And you gave me some resources, which is great. That's all I need. Thanks.
Awesome. Thank you.
I think before we go to the questions and comments, the other thing that I would just add, though, is please know that your experience is valuable to us. And there's lots of other ways that we are seeking out experiences directly from those that have been using the system that have implications for the work that we may be moving forward with. So you'll see a number of initiatives that come through from Healthcare Excellence Canada where we're reaching out to patient partners and wanting to hear of those experiences. So please know that there are other ways in which to share experiences.
Yeah.
Just a comment from Maria about how important senior leadership is. And I think, again, connected with this is also thinking about strategy. And so where does person-centered care actually sit in your strategy or in your mission, vision, values? And, beyond the words, how are you living it out? And what is senior leadership doing to support that? And Mark, thanks for your comments about peeling back the layers of secret sauce. We really don't want this to be secret. That's why we're putting it out there. We want people to be thinking about all of these different elements to ensure that, they're really thinking about their engagement practices and for them to be meaningful. Kathy, we see your hand up if you'd like to come on the line.
Great. Can you hear me?
Yes.
Perfect. Thank you. It was a really great presentation. I do have a question. I am a patient and family advocate. I sit on the Mississauga, Ontario health team, also on the collaborative council. In the journeys that transpire, the projects, I guess, that take place, as a PFAC member or advisor, we have a tendency, and I don't know if this is right or wrong, but sometimes we have a tendency, we know that there are internal groups that go out into the field because they work at the hospitals or with other contractors, etc. My question is, how can a PFAC member be a participant at the critical point of observing, going into the hospital when someone is trying something out, being there firsthand, as opposed to getting that information later in a discussion, because I think visually seeing as well is important, and mannerisms, facial expressions, etc. So I guess my thing is, because we're not employed with anything to do with the hospitals, we are a critical part. We know that patient and family advisors or advocates want to be a part of it, but how do we get into the very beginnings of it and follow through, not just after fact? Thank you.
Thanks, Kathy. Yes, you bring up such an important point. And it reminds me of something that we have done actually at Hull and Bloorview, in that we will include patient leaders on Gemba walks. So when we undertook some work to think about nutrition at the hospital, and there was a team that came together to start to explore it right from the very, very beginning, the team that included family leaders literally walked through the entirety of the hospital, right from the kitchen up to where the patients were receiving their meals, and thought through, how it was done, and the processes and the structures that needed to be in place. And so we were able to, with our staff partners, really understand it, such that when we went to the table to kind of start from scratch and work together, to your point, we had seen people doing the work. We'd looked in their eyes, we'd kind of understood it a little bit better. So I think it hopefully is organizations will take on that responsibility to include patient partners early in the process, and allow them, when it's safe, to physically be there to explore an improvement idea or to explore a problem before we come up with solutions.
Thank you very much. I appreciate that.
I see that Esha and Adeline have put comments in the chat, and there's another question from Jackie. I'll just quickly say, absolutely, I think the importance of education, I totally agree, Esha, of how is it that we help to support everyone in the healthcare system to understand what does good engagement look like. So when you're talking about, Adeline, some of the best practices, definitely the way that it looks now is there are things that happen within various programs at Healthcare Excellence Canada where the work of engagement is absolutely built into the programming. And so people that are engaged with us in virtual care collaboratives and long-term care will be hearing about this work of engagement, where there are supports put in place to support teams that are doing the engagement work to be building on these best practices for engagement. I'm not sure if that quite answers your question, but there's education in that form, and I think there's definitely conversations about going out with engagement capable environments and doing much more of a series that would relate to some of the education around that. Jackie, you've commented, how does a primary caregiver go about introducing this concept of engagement capable environments, and how does HEC go about it? So I've alluded to, the various programs and the various settings that we have, but lots of people end up reaching out to us, and we're happy to help support you to go into your organizations, do presentations, support, provide tools and resources, and help be your thinking partner through what would engagement capable environments actually look like within your settings. So I welcome you to reach out to us directly, and we can have a conversation about what is needed. I'm conscious of time. I see there is one more about senior leadership. Adrian, do you want to take this on, and then I'm going to have to close it off with in the huddle? Yeah.
Yeah, no, I think you know what, we only do have 1 minute, so we might need to wrap it up at this point so that we can make sure that we provide kind of resources and next steps. No.
Okay, so what I'm going to suggest, Jamie, to your question, we will respond to you, and we'll figure out with the team how we do that, but you will hear from us around senior leadership buy-in. So we're ending we've come to the end, and we always love the time that we have together with you. Thank you again for this discussion. As you can see, we have a great lineup of sessions planned for the fall, and the next one happening in October relates to Canadian Patient Safety Week activities, and the topic of conversation is, how safe is your care? How do we build capacity for patient safety in partnership with providers, patients, and essential care partners? You will see on the next slide, I'd like to call out all of the organizations that support our Essential Together program, 12 from across Canada. And on the next slide, a huge heartfelt thank you to the organizations that have already made the pledge and made the commitment to essential care partners within their organizations. And I hope that we will soon be able to add your logo to this as well. And to end off, a huge amount of thank yous to all of you for attending, to Adrian for being my co-pilot. A huge thank you to the interpreters and our production team who really make all of this possible for us. We do ask you to take the short evaluation that is now visible on your screen. And if you're interested in learning more about Healthcare Excellence Canada and the Essential Together program, please visit our website. And we look forward to seeing you in October. Thanks so much for joining us today. And this concludes today's webinar. Have a good day.